Um, Before I introduce the speaker today, I was going to ask, I asked Carlos to do the honors of introducing the lectureship and speaking to us about Henry and the impact he's had on our organization. I know for myself, while Henry was the entree to Yale for me and taught me a lot about when I arrived, what we needed to focus on and my role. And I appreciate that, and I think we're all better off for it. I'm still learning, Henry, so hopefully you'll have patience to teach me some more over the coming years. With that introduction, I'd like to ask Dr. Carlos Mena to just make a few comments.
Good evening, everyone. I have the pleasure, honor, and privilege to talk about a person that is incredibly near to my heart and who has taught me, if not everything, a lot of what I do on a daily basis. And this is Dr. Henry Cavin. Henry, I love you, you know this. Dr. Cavin graduated from the University of Pennsylvania in 1971, then went on to graduate from Yale Medical School in 1975, was a medical resident at the Yale New Haven Hospital between 1975 and 1978, where he went to the NIH and NHLBI, working with Bill Grovers in cardiovascular pathology for about 3.5 years. He was then recruited by the late Dr. Barry Sarrett, rest in peace, to come back to Yale in 1981 as a cardiology fellow. Joined the faculty a year later, at which time there were about 10 faculty members in the cardiology section. Think about that nowadays. He established the Yale Cardiovascular Pathology Study Unit in 1982. And since then, he used to do something that it was incredibly important for our training as fellows, which was known as Hearts with Henry. He then was the Yale New Haven Hospital CCU director for about 26 years, was the founding medical director of the Yale New Haven Hospital Heart and Vascular Center, was the associate section chief for cardiovascular medicine for about 20 years between 1994 and 2014, then became the interim section chief of cardiovascular section for about 4 years between 2014 and 2018, appointed medical director of network development for Yale Medicine in 2018. Of note, Dr. Cavin started the angioplasty program here at Yale together with Dr. Michael Clement, another giant of cardiovascular medicine, in 1984. And they established one of the first angioplasty fellowship programs in the country. However, and despite all these achievements, there are many other things about Dr. Cavin that one can highlight. And one of them would be his personal aspect. Henry, when I used to ask him what was the thing that he enjoyed the most about being a faculty here at Yale, his answer used to be, was that of mentoring fellows and junior faculty. I think that most of us will relate to the fact that when he was our chief, he was an incredibly leader who was thoughtful, who would always listen and have a way to answer our problems. I am very honored and grateful that we have the opportunity to celebrate a long career full of success. His wife is in the room today with us. So for the Cavins, congratulations. And we have the pleasure to have Dr. Rick Nishimura, another giant of cardiology, giving the lecture.
Thank you. So just a couple of announcements, and then I will introduce Dr. Nishimura, who probably doesn't need much of an introduction, but I'll give him a brief one. First and foremost, make sure that you get your CME credit for today. And we have several in the next few weeks scheduled. And so please be aware of the upcoming internal as well as external speakers, as well as the faculty meeting that's been arranged in the middle of the next few weeks. So with that, I'd like to just introduce briefly Dr. Nishimura, who is truly also a giant in cardiovascular medicine, and I think really a perfect person to invite kick off the Cavan series. Dr. Nishimura went to Knox College and then went on to ended up at Rush for medical school before settling in Mayo, where he did his residency in internal medicine and continued on to the faculty for over, I think, 30 plus years, where he had a tremendous impact. It is no joke, and I printed it out, that he has won over 3 pages worth of awards for his teaching excellence across Mayo, across the American College of Cardiology, and in multiple different venues. He is a master clinician and master educator who has taken those responsibilities on very seriously. His contributions to clinical cardiology are immense, and I think is one of the fathers of how we pursue our evaluation of hemodynamics. I know he had a wonderful session with our fellows this today, and also really a founder, arguably, of the construct of a structural heart disease program, and his focus for much of his career has been on the topic that he's going to talk to us today, which is valvular heart disease. So without much further ado, I'd like to introduce Dr. Nishimura and thank him for joining us for the Cavan Lectureship.
Thanks very much, Eric. And Dr. Cavan, it's really a pleasure. You can see from the applause that you got here that you were a beloved figure, and it's just so nice to be your first honorary lecturer. So thank you and congratulations. We're going to talk today about valvular heart disease. And oh, I see. Good. I see a lot of the fellows here. And they'll teach us everything we need to know about valvular heart disease. But what I want to do is I want to talk about a new paradigm that we have in evaluating, managing, and treating these patients. And of course, we've talked about this clinical case stuff. I'm going to start out with this young man. 58 is, for the fellows, is still young. You have to imagine that. Who came with a diagnosis of aortic stenosis. Now, he's an attorney, but you shouldn't let being an attorney affect how you take care of the patient. But it seems that we have a lot of them. So he's asymptomatic, he bikes, jogs, no limitations whatsoever and no medical problems. He actually had a treadmill test done by his primary care physician, went 10 minutes, 10 Mets, no problems. When he went to his local doctor though, there was a murmur heard, an echocardiogram was done, the diagnosis of severe aortic stenosis was made. And he's heard all about these TAVIs and these new devices and stuff like that, and comes to, let's say, you now for advice. So fellows, he's coming to you now. What are you going to do next? See how smart your fellows are? So you examine the patient. That's very good. I like that. And on examination, it's classic. There's a delayed carotid upstroke. The lungs are clear, so there's no heart failure. There's this mid to late peaking systolic ejection murmur. And the fellows know that even though there's many articles saying now that the stethoscope is dead, it's very important in valvular heart disease, because unless you have this kind of concordance between the examination and your imaging tests, you need to do something else. There's something else going on here. So this is classic aortic stenosis. And here's the echocardiogram, which shows that it's not plain, but the left ventricle is of normal size internally. There's some left ventricular hypertrophy. There is a mean gradient of 42 millimeters of mercury across the aortic valve. So by our quote guidelines, and we've talked about guidelines and guidelines, we're in the definition of severe aortic stenosis. And as with anybody who has aortic valve disease, you have to look at the diameter of the aorta, because there's aortopathies that are associated with aortic valve disease, and it was 4.3 centimeter. So we have that. And normally I do kind of a poll here, but just the fellows, I want you to raise your hand. How many would do what we call watchful waiting? So the fellow, you have to vote once, okay? And nobody's, you got to have one person watch, huh? How many would do a surgical aortic valve replacement? Okay, how many would do this new TAVI thing? So we got some interventionists in the audience. Okay, now, for those of you taking your boards, you know that you have to take your answers according to the guidelines that were written by the ACC, AHA, and ESC. And if we look at what the guidelines say about severe aortic stenosis, if they're asymptomatic, if their gradient is 42, 58 normal treadmill test, there actually is no indication for aortic valve replacement. Even though all you guys wanted to stuff these catheters in, if you follow what the guidelines say and you answer that on your boards, you would be docked. Okay. Now, what's in the guidelines isn't necessarily what you should be doing. That's the discussion we had today. And I'd like to go that into further detail over the next 30 minutes or so, because we now have a new paradigm versus what we had 30 years ago in terms of valvular heart disease. And that includes the timing of intervention. And we've got better interventions now. And thus, we are going to start to intervene earlier and earlier. Now, the objectives of this talk are, number one, I want to describe the old conventional framework for patients with valvular heart disease. Back when Dr. Cabin and Dr. Cohen and I, were practicing a lot, there was a certain criteria that we would use for valve disease, and we wouldn't do an operation on very many people for reasons that I'll talk to you about. I want to then apply the new paradigm for the management of patients with valve disease, kind of lower thresholds for intervention, and the ability to have better and less invasive interventions, and then say a few words about future, what we're going to do in the future with these patients with valvular heart disease. So let's talk about kind of the old approach to patients with aortic stenosis. And at that time, this is familiar to, you remember these things here from Ross and Brownwell back in the 1960s, who said in patients with aortic stenosis, they would do very, very well for years and years and years, and only when they develop symptoms would they go downhill. So there's no need to really have to worry about a person who's asymptomatic, is what they had said. And at that time, we had these type of valves that you don't even see anymore, but they were the only thing we had. They were these ball cage valves and these tissue valves that would have a lot of problems. The operative risk at that time for an aortic valve replacement was 8 to 10%. 1 out of 10 patients going for valve replacement would die. And at 10 years, 50% of patients with one of these ball cage valves would have an embolic event, and over half the patients would degenerate their tissue valves at the end of the 8 to 10 years. So thus, you really say that you weigh the risk of operation versus the risk of intervention, the risk of operation, the consequences of the operative intervention. It didn't look like there was any downside to waiting. So the indication for operation at that time was to wait till symptoms, or if that afterload was really overwhelming the left ventricle and the left ventricular ejection fraction started to dramatically drop, that's when you would intervene. And that's, you remember, that's what we had back then. Now, as we go further, we started getting natural history studies. And the reason we're able to get natural history studies is we now had echocardiography, which could document objectively the severity of a valve disease. So you could then say, we're gonna follow these patients out for years and years and years, because most patients now started to get echoes if they had a heart murmur. And this type of natural history study applies to all valves, but I'm going to concentrate on aortic valve stenosis here and then go into mitral and aortic regurgitation. But if you look at the outcome of patients with asymptomatic severe aortic stenosis, you can see that at 5 years, 3 out of 4 patients either developed heart failure or died. So the outcome wasn't as, quote, good as what Ross and Brownwell had initially said. And the question that you have to raise is that, well, if these patients with severe asymptomatic have a poor prognosis is untreated, what actually is going on? And that's where this new paradigm comes in about, let's look at the threshold for intervention. Now, you remember that Ross and Brownwell that I showed you, doing well, and then boom, deteriorate. It's different than that. You've got a patient who develops aortic stenosis, and it might be mild to moderate. They might have it for a number of years or decades. Then it becomes severe. So it becomes hemodynamically significant on the left ventricle. And they're still going to do pretty well for years because they developed a compensatory hypertrophy. And for the fellows taking your boards, remember that wall stress equals radius times pressure divided by thickness. So by increasing the thickness with hypertrophy, you normalize wall stress and they should do well for years. Now, at some point in time, they are going to drop their ejection fraction. And some point in time, they are going to start to develop symptoms. But there's this point right here that they're going to start to have a poor outcome even before they drop the ejection fraction and even before they develop symptoms. And that's because, and we know this for all valves now, long-standing pressure or volume overload will start to cause intrinsic, slow, but progressive myocardial damage that we're not going to be able to detect by looking at the ejection fraction and certainly by symptoms. So this myocardial damage, now that we've got all these imaging people here and you're looking at your MRI scans, we know that there's gadolinium enhancement defects with extracellular matrix changes, reactive fibrosis, and replacement of fibrosis. And we're seeing those changes on these asymptomatic patients with severe aortic stenosis. And we do know that if they develop that, their mortality is going to double, even though they're asymptomatic and even though their ejection fraction remains normal. So let's put this kind of in perspective. We've got this myocardial, we've got this kind of, let's say, natural history of events that occur here. And for the fellows, you want to apply the ACC, AHA guideline stages because that helps you determine what to do. We actually stole it from the heart failure people for all your heart failure colleagues, but stage B are patients with mild disease, kind of at risk. Stage D, severe disease, but symptoms. Stage C2, severe disease with a drop in ejection fraction. But stage C1 are those patients who have developed severe stenosis, but haven't developed symptoms or a drop in ejection fraction yet. And we know that we follow stage B, we'll definitely intervene in stage C2, we'll definitely intervene on stage D, which is why when you make your notes, and we're talking about notes, what you got to do in your notes is you don't have to cut and paste and copy all of the echo and the lab reports. Just give us a little paragraph as to what this patient has, what stage they have, and what's going to make you go one way or another. You know, don't make your 10 pages of the epic notes. Just tell us what you need. Right. Okay, so the question is what do you do stage C1? Because before we would just say, and at the guideline committee, there was a lot of discussion on this because we had some really old people in the room who said, no, you never operate on an asymptomatic patient. And Gene Brownwell actually used to say, you know, we wrote this paper on asymptomatic AS. He said, the most common cause of death in a patient with asymptomatic aortic stenosis is the operating room. So this is Gene Brownwell, you know, and what are you going to say to Gene? So that was kind of the going thing. But we know now that we need to do something differently. Now, aside from the fact that we know that the prognosis is not going to be as well, we've got better and less invasive interventions. Our valves now are beautiful. I mean, you put in a mechanical valve, they will never wear out. And for the fellows, when we had those Star Edwards valves, we had INRs between 3.5 and 4.5. So you can see how they would bleed like stink if you had long-term anticoagulation. Now with our Onyx valves, we can do INRs of 1.5 to 2. So the bleeding rate is much less. The tissue valves are much better. The longevity of the tissue valves is much better, especially in a 60 or 70-year-old person. And we have TAVI. And the first time, I mean, being in the lab, the first time you see something like this, you just are aghast. In the past, we used to try to take balloons and blow them up, and it might work for a little bit, and then they come back even more symptomatic. But TAVI has just been a remarkable new intervention that's completely changing the landscape of the way we do aortic stenosis. Because after this, look at the pressures. They've got a prosthetic valve, and they're in the hospital. Used to be overnight. We're letting patients out the same day now if they do well from the transfemoral approach, a dramatic relief of obstruction within seconds. And fortunately, the industries have been, let's say, insightful enough, and Eric knows this, that they started doing randomized trials when a new device came out. And they then proved that TAVI in operable patients was better than medical therapy, and that high-risk patients, TAVI was as good as surgical AVR. So in our 2014 guidelines, we said this, that we'll do TAVI in inoperable, and it could either be SAVI or TAVI in the high risk, and the rest should be surgical. But then further randomized trials came out with intermediate risk patients and found a comparable results. And then several years later, even more studies came out that it said extended to low risk patients. So over the course of just 3 to 4 years, you can see that the indications for TAVI have dramatically changed based on randomized trials. And the risk of a TAVI, as you know, if properly done in the proper patient, is very, very low. So let's look at that stage C1 here. And we're got to think about weighing the risks of the operation and the benefits of operation. So I think our job now is, since there still will be some patients who do very, very well with severe stenosis, we need to identify patients who have a poorer outcome. And if they're at low risk for intervention with either surgical or transcatheter aortic valve intervention. So that's where the number of studies that have come out have really affected our practice, because they've looked at other parameters to try to take these C1 patients who are asymptomatic, who have severe stenosis, who have preserved ejection fraction, who have a good exercise tolerance, and say, well, let's see if there's any higher risk features, and that would be an earlier intervention. So this came out on the left, which on the y-axis is the event-free survival, and on the x-axis is the number of years after the diagnosis was made. The different lines tell you how severe the stenosis is, and you can see as the gradient increases and the stenosis goes from severe to very severe to critical, the prognosis falls. Another one is something simple like a BNP, measuring diastolic filling. If the BNP is elevated, the prognosis goes down. So the more severe the stenosis, the higher the BNP, the worse stenosis. This is the thing that we were talking with the fellows today. It's your job to even get us more information. Because if you can show that once we start to see GAD defects on MRI scanning, or we've got severe diastolic dysfunction, and we got strain people in the room now that I know are working on strain, maybe we might be able to predict who's at risk and who's not at risk in that symptomatic, asymptomatic patient. So as we look now today in these patients with asymptomatic severe aortic stenosis, we want to try to get to them before myocardial damage. And this is just a list of the other things that you need to look at. And this has made it, somewhat to the guidelines. But actually, when the data emerges on myocardial strain and gadolinium enhancement, we're going to be much better off and be able to predict who's going to do well and who's not going to do well. And I'll get to your AI stuff in just a little bit here, okay? Because that's going to make a huge difference. So when do we intervene on this 58-year-old attorney with severe asymptomatic aortic stenosis? Well, if you think about it, 2 or 3 patients are going to die or develop myocardial damage if you wait. The risk of intervention now should be less than 1% at a good reputable center with great surgeons and low-risk patients. So in our own practice and in my own practice, I'm using this and then doing a shared decision-making process. Because there are some people who say, Doc, I got all these things, I got these clients now, I got these trials coming up in the next couple of years, I don't want anything done. It's going to safe for me to wait. And I said, yeah, it's safe for you to wait if that's what you want to do. Other people say, I don't want this hanging over me. I don't want to come back and see you every 3 to 6 months. Do something now. We do it now. So this is where the shared decision-making comes in with this type of approach. And there's no right or wrong. There's no let's do it. There's no black or white, so on and so forth. But this is where you have to become a real doctor. Talk to the patient. Tell them about the pros and cons of each approach. And together you can make a decision. Now, as we talk about the guidelines, and I've gone this over with the fellows, the other thing you have to remember is that in the guidelines, we have all these algorithms. We say, well, if your valve area is less than this, we're going to do that. If your end diastolic dimension's greater than this, you're going to do that, so on and so forth. We give what we call cutoffs. And cutoffs are, well, if the valve area is less than 1, it's severe. If it's greater than 1, it's not severe. But you all know in your practice that you can have a patient come in with a valve area 1.3, but be symptomatic and will benefit from an operation. You might have a person come in with a valve area of 0.8. I think one of you were telling me about that, who'd be a 90-year-old woman who's still doing her Zumba aerobics and not having any problems at all. And if you then repeat a valve area that might be 1.2 in an echo lab 2 days later, the same patient might have a valve area of 0.8 because nothing's perfect in what we measure. So I want you to get away from these cutoffs. And I say this again and again and again because I've seen our fellows take patients who are severe, they're symptomatic, their examination is severe, but their gradient's only 38, and they say, well, it's not severe, we don't have to do anything. So I want you to start thinking more in terms of this kind of continuum, okay? And that continuum is such that, well, if they're over there on the far left in the green, it's not severe. In the far right, it is severe, but anything in between, now you got to start thinking and using your clinical judgment. So again, this goes back to this clinical judgment that I know we've talked about again and again and again. So in the patient with asymptomatic aortic stenosis, I think not only do we need to take into consideration how severe the AS and the ejection fraction, but if you look at something like this, and those patients over there in the green, they're probably not significant enough to warrant anything. If you look in the patients in the red, they probably would benefit. And I think anybody else in between, we're going to start looking at all of these other parameters. They might not yet be out in the guidelines, but your job is to read up on things and know what's out there and know what's reliable and so on and so forth. And then if they are at low risk, you talk to them about the pros and cons and what they want to do. And this attorney wanted to go ahead with an aortic valve replacement. We did it. He was out of the hospital in 3 days. He's back to trial law and doing very, very well. I'm very happy with his decision. Okay. Aortic stenosis. We'll say a few words about the other valves and they say a few words about the future. Now, mitral regurgitation is a different animal from aortic stenosis, but it still has this kind of natural history study where there's mild to moderate regurgitation, then severe regurgitation, then there's compensatory dilatation from the volume overload. But at some point in time, you then get the myocardial damage, the drop in ejection fraction, and the symptoms. And we have to decide what's going on and what stage they're in. So stage C2, which is now defined as an ejection fraction less than 60% or an end systolic dimension greater than 40, means your ventricular function is starting to deteriorate. You're definitely going to operate. Stage D, you're definitely going to operate. Stage B, you don't have to do anything. But again, we have the stage C1. Now, the difference in mitral regurgitation is this, is that the onset of myocardial damage in these patients with longstanding volume overload is very unpredictable. I mean, I've had patients that I've seen and they meet no criteria whatsoever for operation. And then they have an operation and postoperatively their ejection fraction's down, which means they've already developed this incipient left ventricular dysfunction. So what are we going to do to these patients with mitral regurgitation who are more unpredictable than either aortic stenosis? And that, fortunately, is addressed by our intervention. Because we now have valve repair, which should be able to be done by many, many surgeons with a very high degree of success. You don't put in a prosthetic valve with its adverse long-term consequences, and there's an excellent long-term outcome. So if you start to kind of weigh the risk of operation versus risk of observation, you know, and you have a patient who can undergo a successful mitral valve repair with a low operative risk and a great chance of repair, meet these criteria, I'm sending all these patients to operation early because I can't predict when left ventricular dysfunction will occur. And once that left ventricular dysfunction occurs, they're toast. I mean, they're not going to do well for years to come. So that's mitral regurgitation. And again, these are these cutoff criteria. But I'm saying don't use the cutoff criteria. Look at it as a continuum. And you know, if you've got these patients with an end diastolic dimension of 30 millimeter and the ejection fraction of 70%, you could probably observe it. And the other thing about mitral regurgitation, if your end systolic dimension's only 30, they don't have a dilated left ventricle. If they don't have a dilated left ventricle, they don't have severe mitral regurgitation. So no matter what the echo says, they don't have hemodynamically significant mitral regurgitation. You observe those. You definitely intervene once they reach the cutoff criteria, but if you have a repairable valve, you're going to move earlier and earlier and earlier. So the difference in mitral regurgitation is that the valve repair has really come up and changed dramatically the way we look at things. Aortic regurgitation, a little different. Okay, so aortic regurgitation has both a pressure overload and a volume overload. And you know, we were talking this afternoon about this young 33-year-old guy that I had who can go for years and years and decades and decades and decades, sometimes without any problem at all with severe wide open aortic regurgitation. It's just that they, as well as everybody else, sometimes will develop myocardial damage, which will precede the drop in ejection fraction and the symptoms. These are our current, quote, cutoffs for when we intervene, ejection fraction less than 55% and systolic dimension greater than 50, but we should probably be thinking about intervening earlier on these patients. The data in the guidelines was based on data that was available at the time we wrote the guidelines. There's new data on aortic regurgitation now, and some of that was from some of your colleagues here. But if you take a look, more recent studies show an excess mortality at even a lower threshold of end systolic dimension and even a higher ejection fraction. So we're starting to kind of say, let's lower our threshold even more and more. And as we talk, there's much more to consider beyond the thresholds of ejection fraction and dimensions, because this is an antiquated measurement that we do now in the echo lab. It's a linear dimension, which only looks at the size of the base of the heart. And here's a patient we had who over the years had severe AR, and the dimension increased only 1 millimeter. But as we actually looked at the volume, because the remodeling occurs in a longitudinal fashion that's not picked up by the short axis, there was a dramatic increase in the volume of the ventricle. So we have to be able to incorporate volumes in there. And we were talking about when we do that, but if we take a look at excess mortality, it's at volumes of greater than 45 cc per meter squared. So again, as we take a look at, kind of this wide spectrum, this is kind of what we're putting together. And I hope we can kind of get this into the guidelines that we can say, we've got patients on the left, we're going to be safe in following. We've got patients on the right there that we're definitely going to intervene. But in the meantime, let's start looking at other things. Let's start looking at the GAD enhancement, the strain, and the volumes to help us make a decision on when to intervene. And I think importantly, especially in aortic regurgitation, you want sequential measurements. So if you see a volume starting to go up and up and up, the ventricle's starting to fail. If you see an ejection fraction starting to go down and down and down, even though it's still greater than 55%, the ventricle's starting to fail. So I think that sequential measurements are very important. Spend the next 5 minutes talking about this AI stuff. Now, we need to have an earlier diagnosis for these patients who have severe valve disease. We're going to continue to talk about the lower thresholds for intervention, how we get that, and less invasive intervention. But if you take a look at this kind of neat study that just came out a few weeks ago, on the bottom are the years. The blue are patients who underwent TAVI. The red are patients who underwent SAVI. But that kind of line there looks at patients, total number of patients who should have had an intervention based on the guidelines. And we know the guidelines might even be a little bit too late. Now, if you look at that, 50% of patients in the United States with an indication for AVR did not receive treatment. We don't know why, if they were misdiagnosed, underdiagnosed, they were, people were scared of sending them for an intervention, but it still stands at 50% of patients did not receive the treatment that they needed. Now, master clinician. So any master clinician should be able to just use your old stethoscope, look at an ECG and say, this is severe aortic stenosis and know something needs to be done. But we don't have master clinicians worldwide like the Yale cardiologists. And you've got a healthcare system now. And you've got a lot of primary care providers who are initially seeing these patients. So what are we going to do to look at this? And this is what we were talking about. So this stuff is all digital information. You've heard these guys talk about their fancy machine learning, so on and so forth. But you can use all of this kind of digital input, put it through a machine learning algorithm, and make the diagnosis of aortic stenosis with a pretty high certainty. Look at the ROC curve there for a diagnosis of significant aortic stenosis by electrocardiography. Now, this is just a patient I had, and I got to show this to you, but it's a 72-year-old man who was followed in our primary care clinic, and back in 2004, had a murmur. They got an echo, and they said, well, it's only mild, so let's just follow him. Now, we did the ECG at that time, and that's what it showed. Okay. Now, years later, there's the ECG. I don't see a change. But what this thing on the left is showing you is the probability of aortic stenosis on the years. And that red dotted line is when the chances of having aortic stenosis become quite significant. So at that time, there was evidence on that AI ECG that this patient was having significant aortic stenosis. Continued to be followed. I can't see a difference in the ECG. Sam Asarvatha, my EP colleague, could, but he's the smartest guy in the world. But I certainly couldn't see any difference here. But the AI ECG said, boy, there's even more of a chance of significant aortic stenosis. And by the time I saw him, he was in heart failure. He was, I mean, he was really, really sick. We had to really do an emergent evaluation and TAVI on him to save him. His ECG had actually changed that even I could see it. but you can start to see there's a progression there on data from the ECG that will tell you that significant aortic valve disease there. And this, if we're thinking about what's going to go on in the community, you need things like this. And there's the echo stethoscope, there's the electronic stethoscope that we're running some machine learning analyses on. The chest X-ray, we're running machine learning analyses on there, and those simple things might be able to tell us who is at risk for significant aortic stenosis in the primary care setting that should be followed. And this is another thing that we showed, is that it even predicts the development of severe aortic stenosis in patients who don't have severe aortic stenosis to start with. So there's a lot of information there digitally that we're just starting to get into. So the future for diagnosis is going to be using this information here to our primary care people so they can refer them to you. Now, next, let's go to, well, who's going to be at higher risk if we let them go, if we continue to follow them? And that's where the convolutional network artificial intelligence comes into play. And you guys are already looking at this. But the lower threshold for intervention, right now we're using these very simple things. We're using the ejection fraction, we're using symptoms, and we're using gradient and valve area. They're very simple though. It's not going to be one size fits all. So that's our current criteria. What you want to do is you want to take into consideration everything like diastolic function, stroke volume, torsion, strain, biomarkers, gadolinium enhancement defects. And there's groups, and I think you're doing the same, who've used this network tomography, gathering all of the information from an electronic health record to try to get more of an N of 1, that your specific individual patient will have this risk of developing problems if left untreated. And that's what the future is going to be. It's not going to be these cutoffs that we have now of a simple ejection fraction. It's going to take all of the information we have, put it in the convolutional network, and be able to predict what's going on there. So, and there's even things we don't know that are probably in the record that we need to be able to bring out and see if they're going to be predictive. So machine learning process provide a precise phenotypic risk assessment for an individual patient. And then finally, just to end off, is right now we have TAVI, we have MitraClip, but I can tell you in the next 3 to 4 years, we're going to have devices that go in every valve and are going to be working, even though they're not working that well now. But with time, we're going to be able to do less and less invasive interventions, probably lower the threshold even more, and really be able to treat these patients with valvular heart disease. So I just wanted to give you an overview of what we used to think back in the caveman days, right? And I think that's important for the fellows to understand. That's kind of where our guidelines started. This new paradigm now, where we really have to be intervening earlier than guidelines to prevent the irreversible myocardial damage that are the consequences of LV volume and pressure overload. And then I know your group's working on it, but boy, really push future changes, using machine learning, artificial intelligence to determine who's got aortic stenosis, who's at risk, so on and so forth. So thank you very much for your attention. Again, it was an honor, Dr. Cabin, and now you're on time for questions.
So you raise your hand if you have any questions.
Eric,
Yes, I was hoping you'd ask the first one.
so that was a wonderful talk, really wonderful talk. Thank you for coming. And Eric, thank you for putting this together, and really appreciate it. And Carlos really touched me, so thank you. So one of the questions that often comes up seeing patients in the office is somebody with aortic sclerosis or mild AS. And their first question is what? They say, Doc, what's the likelihood of me needing something someday? Can you talk about that data, about progression, about likelihood of progression, about rate of progression?
Yeah, so right now we have this blanket statement that says that aortic stenosis progresses at 7 millimeters of mercury per year, 0.1 centimeter per square per year, blank. but that's just an average. And there's some patients who'll never get a problem and some patients who'll get a problem. Anybody want to talk about what you're doing? No, this is the answer here, actually.
So, I mean, Evangelos Economou, one of our star fellows here, has been leading a lot of work in imaging aortic stenosis. He had a cohort study in European Heart Journal identifying severe aortic stenosis on just a 2D parasternal long axis without Dopplers. And when we applied that same phenotype of who has signatures of severe aortic stenosis on people with sclerosis or mild stenosis, we can have a 4x variation and who is, so we are able to now, and this is under review. It was presented at ESC this year and it's under review right now, but it does predict, and we've showed it at Yale and Cedars-Sinai in the UK. So we've shown this now, and hopefully this becomes the way we track and answer that question for those patients.
That's a great question. I think this is fascinating. So this is, when we're retired, these guys are going to pick up, but they're going to just really produce things, that we never even dreamed about. But I think that's great. Yeah.
Thanks. So I have two questions. The first one is about biology. Even when we talk about progression, we're not considering the aortic valve biology. And
Aortic valve
biology, the biological processes that lead to stenosis development. Yeah. And so what is in the future about that? And also about the future of aortic valve disease. What do you think about reversal of calcification and fibrosis approaches? I have a grant on that. That's why I'm
Well, so I didn't even bring this up, but we've got to figure out why valves calcify, why valves stenose. I mean, there's a lot of rabbit work right now on MMP3s and calcitonin and so on and so forth, but it's still rabbit work. And we've got to get to the point where we understand the etiology and the underlying pathophysiologic process by which these works, and then intervene with them, using whatever modality or mechanism or whatever we have. That's the future of valve disease. There's no doubt about it that that's the future of valve disease. I just think that's 5 years off. Hopefully, maybe by 5 years we'll have something, but that's the future.
And the other question I had, sorry for asking two questions. So the old paradigm was about chest pain, aortic stenosis, chest pain, syncope, and heart failure. Everything we talked about today was related to heart failure, cardiomyopathy, fibrosis. So what's happening to chest pain and syncope? And the same thing in the mitral valve regurgitation, that you could have arrhythmias independent of any of these. So what's happening to those cases?
Yeah. So I can tell you in aortic stenosis, we're just seeing a different population of patients now. Back with the Ross Brownwell days, it was usually the young person. The average age there was 50 years old, and they would present very late. Now for the fellows, if you have a person with aortic stenosis and syncope, that's critical aortic stenosis, and you need to get on your feet and do something very, very quickly because they're going to die. So we don't see syncope like we used to because patients aren't as critical and stuff. Angina is just does not occur as much. I don't know why. Probably because the ventricles are not as thick. There's not that big myocardial oxygen demand mismatch. And we're seeing patients earlier and earlier with that. So that's kind of what I would say. As far as mitral valve disease, there's a whole lot of caveats that you talked about, but we were just talking about the patient with mitral annular disjunction and the floppy mitral valve and the person who's going to have ventricular fibrillation and tachycardia, and they're going to fall into a completely different category than what we're seeing from the hemodynamic standpoint. But there's certainly associations that we need to be thinking about that you brought up. Thank you very much.
Wonderful, wonderful talk. And congratulations to Henry for this honor, which is well deserved. I have a comment and a question. The comment is there really was a quartet of symptoms that we used to talk about and be very fearful of the fourth that Mehran didn't mention. I think I learned this from Larry Cohn. One thing that we used to say was that the first presentation of in critical aortic stenosis could be sudden cardiac death. And you didn't mention that at all. And I was surprised about that. I think that was probably overblown back in the day, nothing personal. But you didn't mention it, and I found that interesting, and maybe we're seeing a different population.
Oh no, I'll comment on that in just a minute because I think that's a very interesting subject. But anyway, go ahead. You had something else.
The question is the issue of ventricular remodeling and fibrosis is obviously critical, is key, and to be able to see that early would really, move us in a forward direction. How close do you think we are to incorporating that into, standard of care?
I think we're very close. We've got a number of studies that have shown the adverse prognosis with the gadolinium enhancement defects in both aortic stenosis and aortic regurgitation. We need to carefully look at that at a guideline panel, but I personally feel that and strain, we're about at the area where we can start incorporating it. And that's not saying you got GDE, you operate. That's saying we're going to use GDE if you're in that middle group to help sway one way or another. Dr. Cohen, you want to say a word about that sudden death and anything else?
Well, I wouldn't say a word about sudden death. Thank you. It certainly is the fourth symptom of angina, failure, and syncope. My question is, number one, this is a wonderful talk. It is flawless and gave so much information. My question is, in aortic stenosis, which you spent considerable time on, what has been, in terms of the four symptoms that we just talked about, what has been the impact of TAVR? How much has that changed the natural history? Would Gene Brownwald, who's still alive, agree that TAVR has changed the rubric that Ross and Brownwald said in 1968?
So what's happening? So first of all, I'll leave the sudden death to the second part because it's complex, as you know. But I do feel that TAVI will change the natural history, but we need to wait on randomized trials. Because right now, there's a number of randomized trials about patients who are asymptomatic, what it's going to do, patients who have only a moderate degree of aortic stenosis defined by valve areas, what it's going to do, patients who have, let's say, a low ejection fraction, only mild aortic stenosis, what it's going to do. Now, fortunately, the companies are really investing in this, and we've got to thank our industry colleagues for putting out there that we're going to get you the answer as to whether or not you should intervene earlier and earlier and earlier. And once those studies come out, it's going to completely change the natural history of aortic stenosis. No doubt about that.
Thank you. Thank you.
Now, sudden death. Everybody worried about sudden death with severe aortic stenosis, and it does happen. I mean, I had a number of patients who died suddenly. But if you actually look at the studies, and these are small studies, non-randomized, the incidence of sudden death overall is 0.7% per year in the asymptomatic severe aortic stenosis. And at that time, our risk of operation was 2 to 3%. So we said, well, the risk of operation outweighs the risk of sudden death, but it does occur. Now, I personally feel, because I've had a few patients who had sudden death, and Henry, working in Bill Roberts' lab, I don't know if you looked at the coronaries that much with him, but we do know, at least at Mayo, that there's a number of patients who died suddenly with aortic stenosis who were thought to be very healthy. You section their coronary arteries and they have 80 to 90% stenosis. So I think it's the combination of both that really can lead to that. And in my own practice, if I'm going to watch a person with asymptomatic severe AS, I'm going to get a CTA to make sure they don't have severe coronary disease. Even though it's not in the guidelines, I think it makes clinical sense. Henry, did you work with Bill's coronary stuff? Yeah, so tell us. Yeah. Yeah. But I mean, that coronary disease just is so prevalent. And so anyway, I don't have an answer to prevent sudden death, but that's kind of the way the literature's been. And that's why we don't say it anymore, but I still worry about it. And that's something you talk to the patient about. You say, I can't predict it, but there's a small chance that you could be out there and die suddenly, especially if they're playing singles tennis, which 2 of our patients did.
So I enjoyed your talk very much. And so TAVI is getting better and better, but we know from the bioprosthetic valve how long they last.
Yep.
And I bring back to your case of the gentleman below 60
The
who also has
58-year-old.
mild aortic dilation too.
Yep.
And my question to you is that obviously you're going to do shared decision making and what to use or not. But for your own, in your own opinion, do we have a tool, first of all, to predict who's going to really develop the dilation of the aorta and need that to be actually repaired?
Yeah.
And also, are you thinking that maybe TAVI is going to be valve in valve and then we can kind of continue with that route, or should we do surgery for this gentleman that you presented?
So at the present time, I'm going on data. And all of the TAVI trials have been in older patients. I don't call them elderly because they're greater than 65, so that isn't quite elderly yet. But they're all greater than 65 years old. Those are the patients in the trial. We don't have any idea what's going to happen to the younger patients who have probably an increased propensity to tissue valve deterioration. So, and this is another one of those randomized trials that industry is doing, is they're going to do it on the younger patient. So right now, my own practice is to say, if they're, in that young age group of late 50s, early 60s, I don't do a TAVI. I don't think we can count on valve and valve because 20% of patients might not be a candidate for a valve and valve, number one. Number two, I know that tissue valves are being put in more and more than mechanical valves, but I truly believe that there is a survival benefit of a mechanical versus a tissue valve in patients with aortic stenosis younger than 65 years old. So that's the way I practice. Yeah, so I you know what I do in that case? I get my most experienced surgeon, Hartzell Schaff. I say, Hartzell, look at this aorta. So he'll look at this aorta, and these surgeons, they can just feel the aorta, and they can tell me whether or not it's going to dilate or not. I know we got all of we got all these fancy MRI scans and stuff like that, but that's the way we've been doing it. And experienced surgeons, they can do something like that. So.
One last question, slightly different direction. You talked about sort of the ossification of the guideline in terms of guiding our clinical practice, and you've been on a million guideline committees. Where do you think the future is of how we communicate the complexity and integrate the new information that's coming out at an ever increasing speed?
Our guidelines are antiquated. They don't get updated like they should. One of the things we've done is tried to put them into little knowledge chunks so that you can remove a part of it, insert, so on and so forth. So it'll take 5 years for a guideline. But I think this whole thing of cutoffs is going to go away. And I think what you guys are doing now with the convolutional networking, tomographic networking of combining all of the information together to get an individual risk is going to definitely take over what we have in the guidelines, especially for that intermediate category. And we can tell you when you have to because it's too late. But this intermediate thing, we're not going to be able to say anything with guidelines. We're going to have to do it using machine learning. I know that.
Thanks very much. So along with John Forrest and some of our other partners, I'm one of our structural operators.
Yeah.
And one of the things that we're sort of struggling with right now is, so I was struck by the slide that you had suggesting or demonstrating the undertreatment of severe aortic stenosis right now. And this is a big thing that we're trying to deal with institutionally as well. When we look at our numbers, they're nowhere near where they need to be. And this is outside of moderate as these are patients with severe aortic stenosis that meet indication for treatment that are just not being seen in valve clinic. And I'm just interested to hear sort of how this is approached at Mayo, how you've been able to convince your administration to invest resources in this sort of thing to mitigate this.
Well, the beauty is you got a unified health system now. So you're all on the same medical record, and you got people scattered all over, the states and stuff. The secret is to embed it into the workflow in the medical record. So we've kind of developed this product we call Mayo Clinic Expert, Advisor. And we're saying we're not going to make recommendations, but we're going to pull all the information pertinent to this patient, and we're going to lay on top of the medical record everything you need to know. And within that then are things like, well, this was a 12-lead ECG that said you have a high risk of having a significant aortic stenosis or cardiac amyloid or hypertrophic cardiomyopathy. We'd suggest you get an echo. We know that alerts don't work. So just putting an alert in the medical record isn't going to work. But if you present to a person everything they need to know on one page, they're going to look at that one page. So I think that's what you're going to need to do to get your stuff into play. But you've got a wonderful opportunity now because of your unified health system to be able to do something like that.
So with that, I'd like to join me in thanking Dr. Nishimura for celebrating Dr. Kaplan's accomplishments with us, and a round of applause for both of them. Has some time. I want to take that inch forward, take a 30-minute break before dinner, but we have about half an hour to join in the front view of any questions. I want to ask you about
Hi, thank you for the lecture. What is the difference between the ventricle size between AI and MR?
Oh, because AR has both a pressure overload and volume.
Right, but if we consider a ventricle, let's take the MR, it's not doing well at 40. Why do we wait more for the AI, despite
the pressure and volume overload is what I'm talking about.
Right.
Because if it's a volume overload and your afterload is decreased for the same myocardial contractility,
you get
end systolic dimensions.
Right.
So that's a very good question.
Yeah.
It all has to do with
Right. Thank you.
Oh, are you?